Alrighty, guys, I'm Justine. I'm one of the flight nurses at Apollo Med Flight. I'm going to be talking about anatomy and physiology of the airway. This presentation was put together by Red River Institute. Leanne Jones and Chuck Skinner were the ones that wrote this. So let's go ahead and get started. The respiratory system is going to gas exchange and air exchange. As far as the upper airway and the lower airway, we're going to go into great detail about both of those entities. So your upper airway is going to consist of external nares, internal nares, your nasal septum, the hard palate, concha turbinates, the meatus, nasopharynx, oropharynx, and the pharynx. And this is just a better shot plane. And again, that just shows the upper airway. So you've got your sinuses as part of the upper airway. Just remember a key thing in this presentation, that the division of the upper and the upper airway houses the nasopharynx and the oropharynx and all that entails. So you have the nasal cavity, sinuses, the roof of the mouth and the tongue, the base of the tongue, the posterior pharyngeal wall, and the oropharynx. The lower airway is what houses the larynx, your vocal cords, the vestibular folds, your glottis and trachea, the carina, the main stem bronchi, secondary and tertiary, and then bronchioles and your alveoli. This is just an image of the larynx vocal cords. Also included in the lower airway, your glottis, trachea, and carina. Your carina is going to be this area here that makes a C-type shape that's going to separate the two main stems. That's the little piece that you're going to inevitably hit with the bougie whenever you go down. Once you get there, you've gone when you know you need to intubate. This is a perfect image of a glottic opening. That's what we're going to be aiming for as far as when we go to intubate. We'll have to be able to differentiate all the different anatomy that are in the lower airways as well as the upper airway. This is just an image of your secondary bronchi, and then the bronchioles and the alveoli. From this presentation are the alveoli, are the functional unit of respiration. Very important to know. And this is just surfactant that has to do with surface tension. These are different images of alveoli that have surfactant and that don't have surfactant. This is that important component that's made or supplied in infants whenever they're born. A lot of times if they're going to be born premature, the mother will receive a shot to boost that surfactant output so that they will have the surfactant. That's just that mucus type substance that's going to help slick those alveoli. It keeps them open. And then this is different images of regular alveoli and then fibrous alveoli. And that would be important with your different respiratory processes. So the physiology portion of the respiratory system deals with ventilation, pulmonary function tests, tidal volume, bronchospasms, any residual volume, diffusion, respiratory control. And we go a little bit into that as the presentation goes along. And some of the main ways that that occurs, it's going to be, one of the ways is with diffusion. And that's just the process by which different molecules, as shown in the image, are going to be intermingling as a result of kinetic energy. And it's just a way that they kind of mix. Typically, they go from an area of high to low concentration. And then they could also have potential for movement via osmosis, and that's just like a physics property stating that whenever there is a permeable membrane present, it depends on high pressures and low pressures as far as how the molecules are going to move back. Cilia are important to know about. They're like little legs that can push any kind of debris or dirt or anything that's not supposed to be in the respiratory tract. They're going to push all those things out, good stuff in. A lot of people that smoke or are around smoke cause damage to their cilia. And then this process is a little bit more difficult for those people. Then in this area, there's also mucus production, which forms as a second line of defense for protection from anything entering the airway that's not supposed to be in there. There are 4 major functions of the lung. The first one, it's a reservoir for blood. The pulmonary circulation is the largest vascular bed body and is the only one that receives the whole cardiac output. The second function, the filtration of clots and inhaled substances, because if not, those would just go straight into the vasculature. The third function is the metabolic function, which the production of surfactant converts to angiotensin 1 to 2. And then fourth, for gas exchange. Ventilation is going to be defined as the movement of air into and out of the lungs. It can happen by diffusion, perfusion, distribution. It's a very complex process. Different components influence ventilation. Some of those include the elasticity, lung compliance, any resistance, pressure, and gravity. Those are all important to note whenever you're talking about how and things that we could potentially change so that we could ventilate them more. So elasticity and compliance, normally the lungs are quite elastic, which allows them to stretch and fill. The elastic properties of the lungs are determined by compliance. The more compliant the lungs are, the more elastic and stretchy they are. Lungs that are less compliant are stiff and difficult to fill with air, and that's going to be in different disease processes that you would notice with the lungs. But typically they're very elastic and pliable. Compliance is calculated as a change in volume over the change in pressure. Resistance, pressure, and gravity. Resistance to the airway must be overcome to generate airflow into the lungs. So if there's an obstruction, it's not going to happen. So we would need to remove that obstruction, whether that be a foreign body or narrowing. Resistance is mostly determined by the size of the airway. So the smaller the airway, the more resistance there is to flow. And we would think about that as far as with our age span, children typically have the most narrow of airway, and adults tend to have a larger diameter airway. Resistance is asthma, which could cause a narrowing of the airway. Asthma is typically like an allergic reaction, so anything that has to do with that causes the airway and makes it more difficult for patients to get air into the lungs where they can exchange CO2 and oxygen. Pressure, air flows from an area of high pressure to an area of low pressure. And then gravity, blood will sink. In an upright person, blood will sink in the lowest area of the lung, so whenever they're sitting up, it should go all the way down. That doesn't only have to do with blood, it could also do with fluid. Whenever people have pneumonia or aspiration pneumonia, you want to tilt that head of the bed up a little bit so that we're keeping that down low and giving a chance for at least the top portion of the lungs depending on how much fluid is in there, to have that exchange of oxygen so that they're still perfusing well while we attempt to get the fluid out if we can. If a person is lying on their back, blood flow will be the greatest to the back of their lungs. So control of ventilation. The brainstem is going to regulate automatic ventilation while the cerebral cortex allows for voluntary ventilation. That's very important to know because if you have a patient with a head injury to those areas, you're going to expect them to have difficulty maintaining their airways and breathing and ventilating. In the brainstem, the medulla is responsible for the basic rhythm of breathing. The pons is responsible for limiting inhalation, and thus it triggers exhalation, also controls the depth of respiration. That's the pons doing all that. You have neurons in the spinal cord which process info from the brain and from peripheral receptors. You have central chemoreceptors in the medulla, peripheral chemoreceptors, and then stretch receptors that are in the airways. And they cause the Herring-Brauer reflex. Lung gas inspired and expired during normal ventilation. That's going to be your volume. A must know about that volume of it, because this has everything to do with what we do when we take over somebody's airway and determine how much volume we need to give them to adequately fill their lungs. So normal is 500 to 1,000 mils or 5 to 7 mils per kilo. We must remember that. That's very, very important. Your inspiratory reserve volume, maximum volume of gas that can be inspired after a tidal breath or an extra large inhale. Normal is about 3,001. Your expiratory reserve volume is the maximum volume of gas that can be expired from end respiratory position, so a large exhale. And that's going to be exhaling about 1,000 to 1.5 mils. Your residual volume is going to be the volume of gas that allows the alveoli to prevent collapse, so the amount that stays in there residually after you're done breathing. Normal amount is about 12 to 1,300. Your total lung capacity, the maximum lung volume following full inspiration, composed of your tidal volume, your RV, ERV, and IRV, everything we just talked about. Normal is 5.8 to 6 liters. Functional residual capacity, or your FRC, volume of gas remaining in the lungs at the end of a normal expiration. This is going to be composed of your ERV and the RV, and the normal for that is 2.3 to 2.4 liters. So each component is very important to know and how it affects the other one. Your vital capacity, which is a must-know value, super, super important. A normal is 12 to 15 mils. That's inspired as much as possible, and then expire as much as possible. Dead space ventilation is when we breathe. Air moves through areas in the lungs that take part in gas exchange, so your alveoli, and those that do not, which your trachea does not. The areas that do not take part in gas exchange are called dead space. So we have to consider all of our dead space whenever we're ventilating. You may add a little bit more to get through that dead space, but you don't want to necessarily fill that dead space because it's not taking part in gas exchange, as are the areas such as the alveoli. There are two kinds of physiological dead space: anatomical, which are things such as your trachea, your nose, and your bronchi, and then alveolar, which is a negligible amount in healthy people. The normal amount of dead space is minuscule. It's about 150 mils, but it is relevant. Normally, the ventilation to dead space ratio, let's see. Let's see, so this is saying it's 0.3. That's not our ratio. I do believe that it's going to be a 1-to-2 ratio. All right, so that brings us to VQ mismatch. So let's talk about diffusion a little bit. The second variable in gas exchange is going to be diffusion. Remember, we use osmosis and diffusion typically. Diffusion is the movement of the gas from the area of higher concentration to lower concentration. It's going to be the ability of a gas diffuse across the alveolar capillary membrane, and it's going to be affected by the thickness of that membrane because it's got to go across the membrane. So however thick it is, it's going to be a little bit harder for it to go across. We have to think about the surface area, the gradient, and the ability of the gas to diffuse. Distribution of ventilation. So the alveoli at the apex are larger and less squished by lung tissue. They're less compliant and don't stretch well, therefore they receive less ventilation than the base. In the upright person, the base of the lungs receive about 4 times more ventilation than the apex. So that's why it's important to get all that fluid. If they have a lot of fluid in their lungs, we've got to figure out how to get that out so that they can have better distribution. Ventilation, I apologize. Distribution of perfusion, blood's going to sink. So in an upright person, gravity causes more blood flow to the base of the lungs than the apex. In the supine person, there's more blood flow to the back of the lungs. So the relationship between ventilation, normally alveolar ventilation is about 4 liters per minute, and pulmonary perfusion is about 5 liters. Therefore, there is slightly more perfusion than there is ventilation. This means that they're not a 1-to-1 relationship. That perfusion ratio describes the relationship between perfusion. So just keep that in mind. As far as shunting, shunt's going to be present when blood returns to the left atrium unoxygenated. There's a small degree of shunting present normally as blood from the heart and the bronchiolar veins bypass the lung. However, this physiological shunt is very small, and it's only accounted for about 5%. Any abnormal intrapulmonary shunting occurs when blood passes by an alveolus without picking up any oxygen. So if there's ventilation, is what that's saying. This can occur with mucus plugs, atelectasis, pneumonia, or tumors. And that is the anatomy of upper and lower airways in the respiratory system.